On behalf of the Sociology, Anthropology, and Criminology Department at the University of Northern Iowa, I would like to welcome you to our Diversity Colloquium. I would like to begin by acknowledging that while we are gathered virtually, UNI resides on traditional Indigenous land. Cedar Falls, Iowa is located on Iowa, Sauk, and Meskwaki, Whatcom, and Ochepe Shakogan land. Tonight's event is in partnership with the Office of the Provost and the College of Social and Behavioral Sciences. The Colloquium Committee and I would like to express our thanks to Provost Walhart and Dean Bass for their support. The Diversity Colloquium is a series meant to highlight the work of UNI faculty, students, and local community members and organizations to build a more inclusive and diverse society. My name is Cameron Warren, and I'm an assistant professor of sociology, and I will be serving as the host and moderator for tonight's panel. Our panel this evening is about health inequalities in the age of COVID-19. And we have panelists from across the UNI and the Cedar Valley community here to discuss their research and professional experiences related to health inequalities in the pandemic era. So as moderator, I will be facilitating the discussion tonight, and I encourage you to watch and listen, and if you have questions, to insert those in the Q&A. So we will attempt to get to some of those towards the end of our conversation. So now I would like to take a moment to welcome our panelists this evening, and we'll go in order they've been listed on our promotional materials. So first we have Dr. Adam FROYUM Royce. Dr. Royce received his medical degree and a master's of public health degree from the University of North Carolina at Chapel Hill. He completed his residency in family medicine at the Northeast Iowa Family Medicine Residency Program in Waterloo and has served on the faculty there since his graduation, seeing his own panel of patients and teaching new medical school graduates the specialty of family medicine. He holds adjunct clinical teaching positions with both the University of Iowa and Des Moines University. Since 2018, he has served as the physician member on the Black Hawk County Board of Health. Dr. Royce will bring us a physician's perspective on the pandemic, as well as insights from his role as a county board of health member. So thank you, Dr. Royce, for being here this evening. Next, we have Reverend Abraham FUNCHESS, who is the executive director of the Waterloo Commission on Human Rights. Reverend FUNCHESS is the oldest son of Abraham and Bernice FUNCHESS of St. Matthews, South Carolina. Recipient of many awards and recognitions, Reverend FUNCHESS is most proud of receiving the W.E.B. Du Bois Award for Social Activism from Hampton University in Virginia and the Bishop James S. Thomas Leadership Award from former Bishop Julius C. Trimble of the Iowa Annual Conference of the United Methodist Church. FUNCHESS is currently pastor and building administrator of Jubilee UMC Freedom Center, and as I mentioned, executive director at Waterloo Commission on Human Rights. Married to Veronica McGee with one son, Solomon, who just graduated Ivy Business School at Iowa State. Reverend FUNCHESS is author of a children's book entitled ROISE and is the founder of MLK New Jerusalem, LLC. Reverend FUNCHESS is currently working on his second book and adds to our panel the perspective of on-the-ground activism, politics, and advocacy at a community level during the age of COVID-19. So thank you so much, Reverend, for being here with us this evening. Next up, we have Dr. Francis DEGNIN. Dr. DEGNIN is an associate professor in the Department of Philosophy and Religion here at UNI, where he specializes in bioethics and continental philosophy. He serves as the ethics consultant for both Mercy One and Unity Point in Waterloo, for the Iowa Veterans Home in Waterloo, and for the Legislative Advisory Committee on Inherited and Congenital Disorders, and as vice chair of the Board for Pathways Behavioral Services. He also serves as a night relief chaplain for Mercy One. In terms of COVID, Dr. DEGNIN advises hospitals on their COVID pandemic triage policies, including issues of diversity and equity, as well as consulting on individual cases as they arise. He also served on a university committee advising the university on COVID issues around opening the university in the fall of 2020. He has written multiple articles and a book titled Facing Death, Facing Oneself, an Exploration on Living. He has received several awards for service, including the Nielsen Service Award and the Viridian Community Engagement Award. Dr. DEGNIN brings a wealth of academic and community-oriented experience to our conversation. Thank you for being here, Dr. DEGNIN. Next, we have Dr. ASHLEIGH KYSAR-MOON. Dr. KYSAR-MOON is an assistant professor of sociology here at the University of Northern Iowa in the Department of Sociology, Anthropology, and Criminology. Her primary research and teaching interests are in childhood adversity, trauma, mental health disparities, and quantitative research methodologies. Dr. KYSAR-MOON is an active researcher. Her most recent publications address trauma-sensitive yoga interventions and post-traumatic stress and depression outcomes among women, as well as race, ethnicity, and childhood adversity. Here at UNI, Dr. KYSAR-MOON works closely with her students in courses on mental illness, childhood, statistics, and health inequalities. Dr. KYSAR-MOON will be bringing us a unique sociological perspective on health inequalities and COVID-19. So thank you also to you, Dr. KYSAR-MOON, for being with us this evening. Thank you to all of our panelists for joining us for what I'm sure promises to be an engaging and educational discussion. So as I mentioned, as moderator, I will be facilitating tonight's discussion and would like to start with a question that each panelist can weigh in on that will help give us a better idea of the unique perspectives you are bringing with you this evening. So as I mentioned, you're all bringing very unique perspectives and experiences to our discussion. So in your current work, how have you witnessed or reported, researched or advocated around health challenges people have faced in general and health inequalities in particular? So we will take time to hear from everyone just about their experiences during COVID. So why don't we go ahead and start with Dr. ROISE, and then we will see the rest of our panelists.
Thank you first for having me this evening. It's an honor to be here, and I just want to preface things by saying that while I do serve on the Blackhawk County Board of Health, I want to make sure I'm speaking for myself tonight, not on behalf of the board or the Department of Public Health for Blackhawk County. As I think about the challenges presented by COVID, I mean, as a physician, the most obvious ones are the patient care that comes right off the bat. Taking care of patients in the hospital and in the clinic, especially when things started back a year ago. It's hard to believe it's been a year ago. But as we saw outbreaks in our community, and especially amongst some of our lower income, lower health literacy patients, a lot of immigrant populations, and how we translated the concerns of COVID directly to those patients comes to mind first. The other thing that really COVID impacted right away when it comes to access to healthcare was that we went digital, we went virtual almost overnight, and the speed at which we were able to do that and try to keep up with patients, both around COVID issues as well as around just healthcare in general, and the issues of access that comes when you have a pandemic. People aren't supposed to go home. People are scared to go to the doctor, and what do you do for everybody who has COVID and everybody who doesn't? So that's the immediate stuff that I remember back in those initial days of taking care of COVID patients. On the public health side, when COVID came, I think we really saw the department mobilize and center its activities on what public health does best. It started to inform the public of what we knew. It started to coordinate with all of the stakeholders in the community around how we can address this public health crisis. We tried to reach out and educate people, but all recognizing that there is a large amount of disparity that comes with health in general, in our community especially, in our county especially, and the thinking through the layers that COVID is going to bring to those already existent inequalities. I will say right off the bat, I want to give lots of credit to the Department of Public Health and the leadership there, both Reverend Robinson and Dr. Cece Abonye. I think the CDC just put out that their stance that racism is a public health crisis. Many of us have known that for years, and many people have known that for generations. And I think that's nothing that's new to the public health community. I do think ever since Waterloo, Cedar Falls made the USA Today as the worst place for African Americans to live in the country, the department, even before that, they were starting to really put health equity as a lens through which we view public health in the community. And I think that's only been exemplified and brought forth as we go about our work addressing the COVID crisis. So that's a brief summary of some of the things that I remember going through this past year.
Excellent. Thank you, Dr. Royce. Reverend FUNCHESS, if you would share with us a little bit about how in your work you've advocated or witnessed some of the health challenges or inequalities that communities have faced during this particularly challenging time.
Sure.
You're muted, Reverend FUNCHESS.
Yeah, I think
there we go.
I hit space bar accidentally. Yeah, but I would like to begin, first of all, by just saying thank you, Dr. Warren, for the invite. I appreciate the opportunity to share with the others on the panel. I would like to begin with a personal story. I contracted COVID, and it really changed my perspective in a small way. I could just personally identify a little more effectively with the hundreds of thousands of people who were losing their lives to COVID all over the world. One of the things that I found interesting was that one of the symptoms for me was that I could not breathe. My breathing became very laborious. And obviously, this was within the 1 year time frame of the whole world witnessing George Floyd being killed, there in Minnesota, and the asphyxia that's associated with what he endured is what a lot of people are experiencing with the COVID. And so it kind of amplified for me the health challenges associated with non-communicable diseases in community that are already present for a lot of marginalized and disadvantaged individuals in community. But it also heightened, awareness, quite frankly, as you begin to experience vicariously what people might be experiencing when they deal with the social ills of community too. The doctor mentioned, racism and the ongoing struggle that people have dealing with racial assaults, microaggressions, those kinds of things. When I could not breathe, it made me think of the larger, social asphyxia that people wrestle with throughout community. And COVID, quite frankly, we began to appreciate, just pulled the lid off of a lot of the issues that were already present in community. We began to see them much more clearly. People believe that racism began to manifest itself, much more clearly in ways that people could begin to tackle. There have been small advantages with what has transpired with respect to technology and these kinds of things. But in terms of helping people see more clearly, what the everyday ordinary blues person is wrestling with on a regular and consistent basis in communities everywhere, I think is something that has given everyone an opportunity to reevaluate in a way that nothing other than something like a global pandemic could help us see. So again, I just look forward to the conversation and look forward to hearing what the other panelists have to say as well.
Yes, thank you so much, Reverend, for that very personal and poignant story that's connected to so many of the experiences I'm sure we're going to speak about this evening. So I particularly appreciate the term you referenced, social asphyxia. I think that really applies to a lot of the inequalities that we're going to hear about. To give our other panelists a chance to kind of let us know where they've been during the pandemic and kind of how their work intersects or their perspectives apply, we'll turn it over to you, Dr. DEGNIN, to give us a little bit of insight about how in your work have you worked around COVID, witnessed, reported, advocated around some health challenges and or health inequalities.
So, when COVID first began, a couple of things jumped out at me. And the first was spring break, at least in Blackhawk County. My prediction was always that if we didn't shut down spring break right after, within a couple of weeks after spring break, we'd have basically all the students coming back. And that's exactly what happened. We had a couple of cases from a cruise ship that got started before then. The second thing that really struck me, though, was the Tyson plant. And in fact, there are still people being affected by that. I was involved in a situation with the death of a person who had been sick from COVID since last November, not that long ago. And not shutting the Tyson plant was highly troubling, and it kind of highlights the fact that I can stay home most of the time. I do go into the ICU and meet with doctors and patients as I need to. But for most of my work, I'm white, I'm affluent, I can stay home, I can do most of my stuff on Zoom, so I can limit my exposure. But people that have to work in grocery stores, in Tyson plant, in places like that, they're just at so much higher risk. And a lot of them were not allowed to collect unemployment. They weren't allowed to, even if they had pre-existing conditions, they still had to go to work. They weren't included in the ability to stay home. And so the timing of this is all sorts of things. The Tyson plant was, again, very striking because when the first 50 cases were announced, at that point I thought, okay, they're going to shut it down for a couple of weeks to get things under control. And they didn't, and they didn't, and they didn't. And it was only because of local political pressure that it finally got shut down. But we had ended up with at least 1,000 cases in the community and the plant, and just spreading out. It became a super spreader event. Now, the advantage of keeping it, if we had, so Blackhawk County became at that point one of the worst places to be in Iowa for a while. And the huge disadvantage of being one of the first is that we don't know how to treat these diseases. So in the beginning, why do so many people die from it? Well, like in New York City, on the x-rays and so forth, it looked like pneumonia. So they were treating it with ventilator settings that they would use for pneumonia. Well, that turned out to be too high, would actually do additional damage to the lungs. This patient, for example, which was, because it's not just the Tyson employees, it's their families, it's the people they meet with, it spreads to the community. This person who gotten it indirectly from there, he got it in November. Okay, now 1 month later, he probably would have survived, because November to December is when we realized that the plasma therapy, where we give people an infusion of the antibodies for someone who already had it, doesn't work if we wait till you're in the hospital. It has to be done. If you're a person at risk, we have to bring you in right away and do it early. And in December, we did that. In November, and it was even the end of November when this person got it, we were still doing it in the hospital, and it was too late. This person was there for months, but finally died. Now, again, compare this to a couple of colleagues of mine who did get COVID, but they were older and they were at risk. But they got it in December, and they got the infusion in December, and that kept them out of the hospital, and that kept them from dying. And so, not getting, so these communities that get it earlier, they have far more comorbidities, and they keep talking about how, for example, people of color are more at risk. It's not because they're people of color. Let's be really clear about that. It's because they have less access to healthcare. It's because they can't isolate at home as much. They have, far less income, health disparities. They have to live in groups more. It's all the conditions around them. It's not because they're people of color. It's because of other systematic inequities in our culture that put them at much higher risk. So one of the biggest areas, and I'll come back to this in a bit, that I started off at the very beginning, is what they call pandemic triage. And pandemic triage is, what if we end up with just too many patients and not enough resources? How do we choose who lives and who dies? And I think that the systems are pretty good, as best as they can be, for how most of us are doing it. But I want to come back to it, because I'm saying even with the systems, I think as good as they are, they actually still have systematic injustice built into them because of the systematic injustice in society. And so I'll come back to that, but that's an area that I did a lot of education in the beginning. The other side too is just access to resources, even to the vaccine. So my brother happened to, the first thing that happens is those people that are more electronically and connected to news and everything else, and to the right people, they get the vaccine first. Even if you are in a neighborhood or when they say, okay, we're going to send out all the pharmacies, that seems fair. But if you're in a poor neighborhood, which most people of color are, there aren't that many pharmacies. So you get a lot less access there. If the access is mainly online, then, people that are more electronic, they get the access there. So you'll have the people that are affluent going into the poor neighborhoods and getting those vaccines appointments first as well. My brother got the vaccine earlier than he would have. He was eligible, but it was hard to get an appointment because his neighbor's wife worked at a pharmacy and called up and said, we have some extra doses so we can give them to more people. And he came over to my brother and said, get over there. And they took his name down, and he actually literally walked by a whole line of people that were standing outside the pharmacy hoping to get a dose, because he got called and told there was a dose, and they held a dose for him. So So these things all add up, and we'll talk more about this, but I'm just kind of laying out some of the things that jump out at me. So.
Excellent, thank you. And yeah, we do have one question that will specifically talk about some of the inequalities in access and inequity in vaccination rates. But thank you for that brief overview of your experience working during this pandemic time. I would like to now give Dr. KYSAR-MOON a chance to weigh in about bringing in your unique perspective as a sociologist. How have you researched or advocated around health challenges in general or health inequalities in particular during the age of COVID-19?
Yeah, so thanks again, Dr. Warren, and for everyone else participating today. So as a medical sociologist, rather than focusing on individual experiences or cases, I tend to look at the big picture. I look at, systematic patterns in behavior and seeing how those patterns or social forces are associated with health outcomes. And as the other panelists have already mentioned, right, health disparities are not a new phenomenon. They are not unique to COVID. Health disparities have existed as long as this country's been around, right? And what the pandemic has done is put a spotlight on inequalities in what we would describe as the social determinants of health. And some of these determinants of, health outcomes have already been mentioned, right? Racism and discrimination is a huge determinant of, poor health-related outcomes. And Dr. DEGNIN has also mentioned, right, economic vulnerability. We know poverty and unemployment, both of which have been exacerbated during this pandemic, also are associated with much worse health outcomes. We also know that access not only to quality healthcare, but culturally competent healthcare has also been a really important factor in the way that this pandemic has played out, whether certain groups of people have felt comfortable seeking medical care, if there are medical providers that they feel like understand them and their own cultural experiences, puts up barriers sometimes for people seeking healthcare. There's also been a great degree of social isolation that has gone on over the past year, which has also had an impact on people's mental health in particular, in potentially, harmful and lingering ways. We also know that in the neighborhoods where people live in, right, areas with higher levels of pollution are also really problematic. So when we take all of these different factors that have been discussed so far together, right, these social determinants of health, we know that certain groups within American society are at greater risk. So in particular, low-income neighborhoods of color, right, we see worse health outcomes in these areas. And in terms of, the death rates and the infection rates, we are seeing clusters of infections and higher death rates among communities of color, as well as within low-income communities. And, some of these patterns have been persistent throughout the course of the pandemic. And, I'll just echo again what Dr. DEGNIN said, it's not that the pathogen is targeting racial and ethnic minority groups, but it's because of these long-standing inequalities in the social determinants of health that are leading to poor COVID-related outcomes, just like we see for many other health-related outcomes.
Thank you, absolutely. So for the duration of our panel, I will be posing questions to our panelists, and then you will be able to respond to one another, given the initial question. So the first question actually would like to go back to Dr. KYSAR-MOON and ask you to comment as a medical sociologist, what are the trends in health inequalities that we can see throughout the pandemic when we think about race, class, and gender lines?
Yeah, so, I actually pulled some data today, and I know I've got some stat students in the audience, and I told them they had to talk about data and statistics in their papers, so I have some for them. But, the CDC reported that as of April 10th, 2021, that there have been 545,751 deaths attributed to COVID-19. And we know that age has been a significant risk factor, right? 80% of those deaths are among those ages 65 and older. But when we start to break down these numbers by some other categories, like race and ethnicity, for instance, this is when we really start to see the effects of disparities. And, what the data show is that compared with whites, so American Indian and Alaskan Natives are, 2.4 times at greater risk of dying than whites. we see that Latinos are 2.3 times more likely to die. It's 1.9 times more likely for African Americans to die, and also an elevated risk among Asian Americans. And so these are the death statistics. But what we're seeing as well is that the infections and hospitalization statistics are also mirroring these patterns that we're seeing with deaths. We're also seeing, some interesting sort of outcomes with regard to gender or sex more specifically. In terms of infection rates, so the evidence has been, a little inconsistent depending on what data you're looking at, whether men or women, they're being infected at about the same rates, but men are 3 times more likely to need ICU admissions and have greater odds of dying compared with females. And this is based on data from a 2020 study published in Nature Communications, as well as a follow-up meta-analysis looking at, data post 2021. The social class disparities are, again, sort of in line with what we would expect for the social determinants of health. Lower income folks have much higher rates of mortality from COVID-19. And, again, it's really sort of due to these other sort of social factors related to health. And so I don't want to take away everything if others have data that they would like to talk about or numbers.
Great. If you'd like to respond, please feel free to unmute yourselves and we'll keep the conversation going.
I'll bring something else up a little bit, and that is the importance of getting everyone immunized, because a lot of people may think, well, okay, I'm immunized, I'm okay, right? And I don't have to worry about other people or those people that are poor or those people who are in another country. And right now, 87% of all the shots out there are going into the arms of high-income countries. And most of those shots are actually going into the arms of the high-income people in those countries. And so there's both a moral obligation, I think. In fact, there's, CBS News had a thing, talked about one study that said, it looks like the third world, or what we used to call the third world, the poor countries, won't finish vaccinating their first round of vaccination until 2023. But it's not just a moral imperative. It's also a self-interested imperative that a lot of people are missing. And that is that, the more virus there is out there, the more chances it has to mutate. And the more it mutates, the more it will find its way around the existing vaccines. And so the fact that we are not taking care of both our people that are less, that have less at home, but also it's also a worldwide phenomena that we need to address as well.
I guess I echo those things. I think the other thing to think about is largely the mental health issues that come related to COVID as well, and the stress that has come from COVID. We know that as people are able to stay at home and work from home, that stress level is different and it goes down when people need to go to work so that they don't lose their jobs and they can feed their families. That's a huge stress level that we see as well. We know that there's a huge mental health impact of COVID that I don't think we're anywhere near trying to get our hands on. I know patients personally who have really struggled during this time, and it's been really difficult. We also know that as kids have all been home from school, that the mental health issues that come with trying to parent kids and school kids and work your job and take care of your family and do all of those things disproportionately falls on certain members of our communities, especially women. I think that a lot of families still expect the women to take care of a lot of those roles, and they're often the ones that are going outside the home to work caregiving and service jobs that they tend to overrepresent in. So I think that's another. I don't have stats to back all that up, but I think that's another big trend that the data says is there.
It also really supports. I mean, the problem also is in the ICU, when we can't let people into the ICU to see their loved ones, or even to the hospital to see their loved ones if they're sick. That's incredibly stressful and incredibly difficult on both the patients and the families. But at the same token, we don't want to be spreading people around there as well. And so it's just stressful in so many different ways.
Great, thank you all for weighing in on that very important set of statistics and trends that we're seeing in some of those inequalities. So the next question that we'll start with, and we can kind of trail off from there, and we do have a lot of questions coming in live that I will try to intersperse into the conversation as they fit. Some really great questions from the audience. The next question, we can start with Dr. Royce coming from the physician's perspective, but I think all of our panelists are well suited to respond. The COVID pandemic has laid bare many intersecting inequalities that we've discussed along race, gender, class lines, national lines. Now that we are perhaps seeing what many have kind of talked about as a light at the end of the tunnel, there are vaccinations. There are vaccinations, period, right? That's giving a lot of people some hope. People are getting vaccinated, but we're also seeing discrepancies along the same lines in terms of vaccinations. And we've kind of hinted at this issue. How has access to vaccinations and vaccination rates mirrored or differed from some of the inequalities we have seen due to these societal shifts that we've seen during the pandemic?
Yeah, no, I think talking about vaccinations is kind of fascinating in general. I mean, first I want to say that, when it comes to vaccinations, vaccinations are one of the huge public health successes that we've existed in medicine. And that's not due to medicine, that's really due to the public health system. As we think of all of the things that increase life expectancy, vaccines are right up there with antibiotics as to being extremely beneficial. Pre-COVID, every physician has stories about patients who are skeptics of vaccines and having those conversations with patients about why we should be vaccinated. The stereotypical person who has been skeptical of vaccines in the past are often educated, are often Caucasian, and so when COVID comes along and the vaccine skepticism that we have with COVID, the patterns have shifted a little bit. And as I reflect back on why that is, I think there's a couple different things that come to play. One is the rapidity with which the vaccines were produced, and especially under the last administration, the uncertainty about the role of science and how much we trust science and how much we just say that things are going to work, and the skepticism. Because I saw lots of skepticism amongst the medical profession as well as, do we trust these vaccines? And I remember telling patients that I wasn't going to get one unless I saw the studies and could look at the data myself, and not just trust the public officials at that time that these things were going to be safe. The other side of it, though, is that we know that a lot of marginalized populations have a very good reason for being skeptical of trusting the medical system throughout the years, and so I think there's a natural hesitancy to question something new and to make sure that you have the answers. And if you have some distrust in the system, and especially in a health system that hasn't always looked out for you and treated you well, that it's hard to just swallow and say, yeah, this is going to work, and trust the powers that be to believe that. When it comes to vaccines, and really what has seemed to be the best thing to try to help vaccination rates and help people trust to get the vaccine, is really having a trusted healthcare provider, physician that you're able to ask questions to and get honest answers back from, and to be able to be heard and feel like your concerns are heard and they're taken seriously. I know I have patients of color who have told me, when I asked them if they were going to get vaccinated, that I remember one patient saying, I know you're going to tell me to do it, and I trust you completely, so we don't even have to talk about it, because I'm going to get scheduled, and you can call me as soon as you have them, and I'm going to get it right away. And I remember another patient of color of mine who definitely wanted to talk about it. This patient was very skeptical, and we had a long 25-minute conversation about the value of vaccination and why I thought this person should get the vaccination. In the end, I'm not sure if they have gotten it or not, but I think we, having been able to have that conversation with me, moved them dramatically down the way to being willing to think about getting the vaccine, and making sure that they knew that there was somebody who they could continue to ask questions about for. So when I think about the vaccine discrepancy rates, I think there's a lot of things that come into that. We know, as Dr. DEGNIN pointed out, we know that people who have access to scheduling at a pharmacy online, because that's how you have to schedule, is online, that they're snapping up vaccines in zip codes all across the way. I have patients of mine who told me they've driven 3 hours to be able to get a vaccine, and you have to have resources to do that. And if you don't have resources, you're not able to do it. And I think that's a big thing that we're seeing play out as far as some of those discrepancies. We know that as patients don't trust the system, they're wanting to wait and see what happens to more people before they rush in. And the lower health literacy someone has, the more challenge of it is to trust the system and to make sense of the messaging that's being put out there by public health officials. So I think that's the biggest thing that's how I've seen things as a physician during this time.
I'm wondering if,
You want to go ahead and also address, I'm sure people are curious about this because it's creating some more doubt and hesitancy what's going on with the Johnson & Johnson's vaccine.
Yeah, I can briefly. I mean, I think as people have asked about vaccine development and how these came to market so fast, my understanding is the technology of these vaccines has been being researched for a long time, and inserting the specific DNA material for the COVID-19 vaccine into the vaccines was what allowed it to go so quickly. And then companies working together and working through the approval process at an expedited rate rather than waiting for approval for a long period of time has allowed them to get approved this quickly. That being said, once you give a new vaccine to millions of people, we're going to see those 1 in a million rates come through. You can't see those 1 in a million rates come through when you give it to 30,000 people in a trial. So that 7 people now have had this rare blood clot among 7 million speaks to how rare the condition is among people who have been vaccinated. It does not speak yet to whether or not vaccination increases the risk of those rare blood clots. I don't know the incidence of those rare blood clots for the general public, but that's really the comparison. I'm sure that's what the FDA and the CDC are looking at as they think about whether or not to withdraw any sort of approval. In general, whenever I'm having conversations with patients about new technologies or any technology, any treatment, in medicine, it's all about risk benefits. What's the risk of this intervention? What's the benefit of this intervention? And for a specific person, where do they fall along that continuum? And I don't mean to. I'm sorry that 7 people have gotten this rare blood clot. I do think that if it's a 1 in a million shot, that many people, if given the opportunity, will decide that the risks of getting the vaccine are outweighed by the benefit of receiving the vaccine. But we'll see what the FDA has to say and what kind of guidance they have on how much of those rare blood clots can be attributed to the vaccine itself.
And let me add to that, again, that issue, the value of the Johnson & Johnson's vaccine in some respects is for racial disparities and economic disparities. Is so many of the people, like if you're homeless or you have 2 jobs you're trying to work and desperately trying to keep up with things, the ability to make 2 appointments is really, really tough versus just showing up if there's a big mass vaccination clinic and getting 1 shot and done is much easier. So it's really important to have that available. And it may also just be the FDA will just put some additional guidance on it and say, okay, these groups of people maybe shouldn't get the shot, but these people are safe to get the shot. So that abundance of caution, I think, is a sign the system is working well. Now, a reverse of that really made things worse is, and this is the only thing I fault Fauci on, because he went along with it, was saying that we don't need to wear masks in the beginning. And they were doing that really because they wanted to preserve masks for the healthcare workers. He finally admitted that later, but it was misinformation. And because we were told misinformation, that undermines trust. So, and it also undermined the masking efforts when they got going too. So
I think that's true. I do think, as we have pandemics though, I think part of understanding science and the scientific process is that we're going to learn a lot of information really fast. And so when recommendations change rapidly over a period of months, that speaks to me just knowing more about the process. And I sometimes feel that sometimes we're expected to know what to do at the beginning, and it's hard to know how to do that over time. But how to do that messaging well and thinking about the future can be a really tricky thing for sure.
Thank you. So interesting conversation ongoing. I want to pivot a little bit and to you, Reverend Funchess. One of the things that has kind of been brought up is the role of information and community. And I know that, in your roles as the executive director at the commission, as well as having a congregation excuse me, the Jubilee Freedom Center, correct? You are often this person, right? You are a trusted person in your community. I'm wondering if you can weigh in and talk about what you've seen in your community in terms of conversations about vaccination, COVID, et cetera, and kind of weigh in from from that perspective, as well as speak to some of the human rights elements of this conversation that we're having.
Yes, thank you, Doctor. First of all, I do want to apologize too. I may have answered one question too many. That was, I thought they were all directed to me, but I think it was going out to everybody. And it took me to the second question to catch that. But actually, well, I certainly appreciate the doctor talking about the trust that he has engendered among the people that he deals with on a regular basis, and I believe that. I mean. I've talked to a lot of people that are not, very excited about taking the vaccine. They wrestle, with taking the vaccine, and it's been exacerbated by the blood clots with Johnson and Johnson. And so I don't know. I think people are weary. People like me do the best that we can because I share my personal experience and. I talk about the intention of getting the vaccine because if you do have this so-called 1 in a million chance to potentially fight off this pandemic that's been killing people versus being able to survive, then we want to do it. But the risk factors associated with being in some of our communities with diabetes, asthma, cancer, and all these other known underlying clinical risk absolutely frightens many of the people that I talk to. And quite frankly, we're a little nervous about it. They're distrustful of governmental officials. People don't believe that it's just 7 people out of 7 million that have blood clots. They don't believe that. I'm not sure if I believe that. I think that perhaps more people have demonstrated, quite frankly, some kind of reaction to these vaccines that we're not being told. And we think we understand why perhaps we're not being told, because you don't want to destroy overall confidence in taking the vaccine that might lead us to some degree of herd immunity or something like that. But most of the people I talk to do not believe that there's only 7 people that have experienced this kind of reaction to Johnson and Johnson. And for that matter, experience, vastly negative, results, even with Pfizer and Moderna. I just don't, the people that I'm interacting with, they don't believe that. And of course, we've got, a lot of history to support this distrust and that kind of thing. But nonetheless, particularly in the faith community, we try to maintain some degree of hope, to keep moving forward. Quite frankly, with the whole nation's back up against the wall, people have to weigh their options. Either you take the vaccine and take a chance. You've taken a chance. You stepped out on faith. You risk other things in life. Why not take a chance with respect to your health and the health of those you love? And so, but I guess I just wanted to make sure, though, that I did give voice to those people who remain distrustful of this whole process. They're trying to weed their way through all of this, and that's the anecdotal data that I have.
Yeah, thank you. That perspective is so important to be included, and being one of those trusted people in the community. I think it's imperative that you're bringing that voice here this evening. So, thank you. I'm going to switch gears a little bit and go to our Q&A because we do have a lot of questions coming in. This one, I think I will shoot to Dr. KYSAR-MOON. And the question is, do you think the COVID pandemic will help the general public recognize the importance of social determinants of physical and mental health, or will health continue to be viewed as an individualistic trait or problem?
Yeah, thanks, Becca, for that question. I happened to see that in the Q&A, and it was going to be too much to try to type. So Dr. Warren had posed a question to us panelists about sort of what we were hoping would be, maybe some outcomes of this pandemic, right? Or what we might expect to see. And for me, I think that maybe something positive that we could take away from this pandemic is if we do treat the social determinants of health as a true public health issue and responding to these social determinants of health in ways that can, increase equity and reduce disparities. So, I mean, I think it's important for us to, target policies that can improve culturally competent healthcare, including mental health care, having inclusive healthcare practices that don't discriminate or stigmatize anyone. I think it's also important to think about how we can provide better and equal access to educational opportunities for our youth so that we can try to disrupt intergenerational cycles of poverty, right? Which are, very pervasive and lingering health problems down the line. And, we need to also think about improving economic stability. How do we reduce poverty and increase, access to affordable housing and reduce food insecurity? These are, things that have been, attempted to be addressed with some of the latest economic stimulus packages that have come out, right? They're targeted to reducing poverty. But, it's not just sort of these, individual or kind of one-time attempts at fixing these things. I mean, they're much more systematic, right? And, I think that all communities have a responsibility on working on decreasing racism and discrimination and helping our communities of color to thrive and to improve well-being within these communities. We all share a responsibility in that. So yes, Becca, to answer your question, I sincerely hope, I know that many of us are doing work in this area, that, we can make a difference in the years to come in improving health equity overall.
Thank you, Dr. KYSAR-MOON. Another question coming in from Q&A, this was one of our first questions actually from an anonymous attendee, is for Reverend FUNCHESS. And the question is, do you believe that the starting of the COVID-19 pandemic has amplified the fight for racial rights in a time where we are seeing an attempt for greater change? What do you see as those intersections of kind of the dual viruses of racism and COVID?
Yeah. I think that was one of the few questions that I did try to answer. But yeah, definitely. I think COVID did pull the lid off of a lot of those inequalities that were already extant within this country as well as all across the globe. There's a lot of literature out there in all sorts of journals that speak to various countries and the discrepancy, the inequalities that are extant in each of those. And it just helps us understand better what's going on in our country and in our own community. I was just thinking, by the way, that while we were talking about this idea of taking the vaccine, being afraid to take the vaccine, those kinds of things, the anecdotal data that I just presented is borne out in the number of people who are responding by zip code here in the Cedar Valley, interestingly enough. One of the things that we are finding, and this comes from our public health agencies, the Blackhawk County Public Health and that kind of thing, is that targeted vaccination clinics do seem to make a difference, though. I think most leadership has agreed that they certainly don't want to steer anyone towards Johnson & Johnson, but they do want to continue to try to encourage people to go with Pfizer and Moderna because of the perceived benefits of doing so. But definitely, I think that people are more engaged now, with respect to trying to make things right in community, whatever that means. But it appears that, by treating Blacks as the ontological, representation of oppression in community, by treating Blacks and other ethnic minority groups in a way that seems to come across as a little more equitably, is something that people in this community and quite frankly all over the United States seem to be doing, because COVID has taught us that we need each other to survive. And it's also demonstrated for a lot of people, and they're seeing it in ways that perhaps we haven't seen it before, that, there are some people in community across this nation that have not been treated well, historically and present day. Many of the traumas that have followed certain communities are still manifesting themselves over and over and over again. in present day. And of course, one of the obvious manifestations of that is the ongoing police destruction of Black bodies that we see everywhere. It just defies explanation. And this thing becomes fossilized in people's bodies. And unfortunately, Black and brown people who seem to be the victims of this kind of racial assault and oppression, they can't metabolize this kind of pain and injury sufficiently well enough in order to keep thriving. And so I think the pandemic has certainly done a number on us to help conscientious people of all ethnicities to see how we're mutually connected and dependent upon each other. I think it has given new breath to the song by Hezekiah Walker, "We Need Each Other to Survive." And that is a good thing.
Most definitely do. Thank you, Reverend, for that response. Another anonymous attendee has posted a question that kind of piggybacks on some of the issues we've been talking about as it relates to racism and inequalities. And I will let whoever wants to respond take this one, but I think it's important, and I know you all have something important to add. So the question is, the development from the CDC categorizing racism as a public health issue, what sort of effects should we expect from this development in terms of culturally competent care, policy changes, implementation, et cetera, overall health of people of color? How long should we expect to wait before we see statistically significant changes from this development, whether they be positive or negative? Anyone feel compelled to jump in on this new classification?
I think it's a really important question, and I don't think it's an easy question. And part of the reason why I say that is, thinking of the two hats I wear, one in the medical community that provides care, and one in the public health community, because the CDC is really a public health entity, and it identifies that there's a public health concern around racism, and that's racism that affects people's mental health. It affects their living environment. It affects the safety of their environment around them. It affects their job, their income, and everything that stands up in those social determinants of health. The question that was asked seems to be wanting medical side outcomes, which are related and super important, but at the same time, the processes by which it affects those is different. Because if you are looking to change people's income status, to change their job, to change their environment, to change their community, that's going to have effects on their health, but it might be longer term, and we might be talking a generation or two as we move people up and we move their health status up along with it. When it comes to looking at how, when someone goes to the doctor or when someone goes to the hospital, how they're treated and cared for as a person, irregardless of their background or their race or their language or their ethnicity, then I think that's a different question, and that is one that's I think is going to be different in different parts of the country, to be honest. As I guess my third hat is as a teacher of medicine to new people, and in the family medicine training circles, there is a lot of emphasis. And we just had an annual program director spring conference where half the sessions were on health equity, on microaggressions, on how to increase diversity within our training programs and make sure that new physicians of color are welcomed and given leadership position, are promoted to have leadership positions, not given, but promoted to have leadership positions in a new way. That's where the conversation is at right now. How quickly will that spread out to the medical community in general, I think is a difficult thing to know. How quickly will that change the leadership within hospitals within certain places? That's a difficult thing to know. There are communities, there are extremely diverse communities that I think are doing this really well right now across the country. And I think there are places with less diversity that it's not a burning issue, and we're going to see those places struggle a little bit more depending on the leadership that's there, both within the physician community, within the hospital administration, but within the public and the patient bodies and the patient advocacy groups and things at large. So I want to believe we're moving in the right direction. I fear we're not moving quickly enough in the right direction, but I do feel like COVID has provided momentum to get us to continue us along that pathway, and I'm hoping it happens sooner rather than later.
I'm thinking about what ASHLEIGH was saying earlier, and the CDC, basically says that there's 5 determinants basically of risk for COVID is discrimination, healthcare access, utilization, occupation, education and income, and housing. And you're right, those things aren't going to change very, very quickly. And even classifying it's creating pushback. So think about, what's going on in the Iowa, House and Senate right now of, cannot, when the push to say we're not allowed to talk about systematic racism, and yet all the research is it's real, even in things that we're trying to be really fair on. So like I teach pandemic triage, right? Pandemic triage is that horrible decision that we fortunately have not had to make of too many patients, not enough resources, who dies, right? And there's all these things about it. It's really kind of goes to utility of the greatest good for the greatest number. So we look if there's resources for 10 and we have 15, who are the 10 that we can save? We're not going to save somebody that that uses the resources that would cause 2 other people to die. So who are the ones that are most likely to live? And there's even, and I like this about even in the Blackhawk County Public Health, there's even a statement about preference for the vulnerable, so it's kind of a tiebreaker thing. So there's a strong effort there, to look at things in terms of just how do we save lives, as many lives as we can, not on the basis of color or anything else like that. Until you realize that because of all these long-term factors, people of poverty or people of color are all going to come out, or many of them are going to come out on the sicker end of the scale and are less likely to survive. And so even though that's probably the best model we can do, it's still going to be discriminatory. And that's kind of systematic racism there.
I just wanted to interject right here too, just based on what the doctor just said. In the beginning, when they were trying to administer these vaccinations, they were avoiding, the Black and brown communities. It were the socioeconomically well-off communities that were getting the vaccine, and people were fighting to try to get some of this vaccine into some of the more disadvantaged or impoverished communities. And so I just think that was a fascinating reality. It looks like they're trying to, change course a little bit now, which is encouraging. But it was, quite frankly, just a constant reminder that systemic inequality is very, very real in this country.
Yeah, I think that's really important to point out. I mean, the other thing, I think it is something where I don't think the medical, so one of the top public or one of the top medical journals in the past month, that one of the main editors came out and said there is no systemic racism in medicine, and that's at a leading medical journal. And so we know that there's a lot to be done yet in the leadership and getting the leadership that's there to start realizing the problem and advocating for change as well. So I'm hopeful that we continue to make a speedy process, but I think we do have to recognize and name the challenges that are ahead of us too.
Excellent. All right, we'll move on to our next question, which is one that the panelists had ahead of time. So the question is, we are now over a year into the COVID-19 pandemic. As of right now, what are the greatest lessons we can learn from responses to this pandemic? And you can all answer, coming from your own area of expertise. We'll start with Dr. KYSAR-MOON and then go on to Reverend FUNCHESS.
Well, I think I already shared most of what I had outlined to answer this question earlier, but I think it just speaks to, what we've all been discussing, right? That, these aren't sort of individual changes that are, going to make a big impact, in terms of what pandemic response looks like, in terms of, reducing health disparities, right? These are large systemic changes and they're not quick. These kinds of changes take time. And, to sort of go back to what Dr. Royce was saying, right? It is about educating the current, group of students, healthcare workers, right? Not only physicians, future physicians, your nurses, anybody in the healthcare field, educating them But we also have to then educate those that have been in this practice for a long time, because these are the ones that are in positions of leadership. They're the ones running the medical journals, they're running the hospitals, they're the ones responsible for making policies. And so, it's not just waiting 20, 30 years from now for this enlightened group of folks coming out of school to take over, right? It's about doing the tough work with those already in these positions of leadership to acknowledge the problems and then coming together to address the disparities and improve people's lives and increase, their livelihoods, right?
Thank you. Reverend Funchess, would you like to respond with what your perspective of some of the greatest lessons we've learned so far, being over a year into this pandemic?
Right. Well, consistent with the last thoughts that were shared by most of the panelists, wealth inequality is growing. Is not going in reverse. It's getting bigger. And the systemic inequalities that our doctors and others on the panel talked about is becoming clearer, I think. So I think that's one of the things that we've certainly benefited from with the pandemic. But the other thing, too, at least two other things, is that I just want to reiterate, we need each other to survive. I think people began to work together more in ways that they had never done before. And across age demographics, and quite frankly, also across racial and ethnic lines, people realized that we were all in this together. One of the other benefits is that I was reading somewhere that seniors don't feel so isolated because they realize that everybody now is wrestling with the same degree of isolation or something like that. I thought that was very revealing. Because if there ever was a feeling of social isolation, stress for being, part of the most vulnerable population, the idea that now you're not in this alone provides some kind of psychological comfort to these vulnerable populations. But and then of course technology. I mean, I think everybody began to fall in love with new technologies, video conferencing, Zoom, these kinds of things. My God, I've learned so much because of the pandemic on how to use, digital technology in a way that makes things, quite frankly, easier. But it also can be very exhausting because now people say, "Oh no, you have time for the meeting," and now you can cram in 10 in a day as opposed to just one or two because you had to travel before. But all these things have definitely. Benefit in terms of teaching us, educating us, allowing us to see our vulnerabilities at the same time, and the need to do things together. We're, as King said, we're definitely caught up in an inescapable web of mutuality. And I think this becomes very, very apparent during something like a pandemic.
Absolutely. Dr. DEGNIN, would you like to provide your perspective on some of the lessons learned from this pandemic that we're experiencing?
It's a strange thing because what's also really strange is this virus has been politicized like no other virus in history. And that has actually, I think, made things much, much harder to make progress on. And so, so I'm torn to say how successful we'll be or not. I don't know. And the reason is that at times of greatest change is also times of greatest pushback. And sometimes the change wins and sometimes the pushback wins. And we just have to keep working as best we can. But, the other thing I would say is we don't convert people, sometimes even by good arguments. We convert people by, and I think the Reverend's nodding already knows where I'm going with this, by changing their hearts, by reaching out to them. I mean, some people you'll never reach, but other people, it's more about like people to care about, right? And so like the person who becomes more receptive to people who are gay, oftentimes it's because their daughter turned out to be gay, for example, and then they so it's okay. They thought it was a sin and it was a horrible thing, but they love their daughter. And so it's really hard to figure out. I don't know which way we're going to go. I think there's some more awareness here, but there's also a really strong reaction that I'm worried about.
I think there's two things that kind of come to mind, and one to me, in addition to what's been already said. The one is, as we think about telehealth and new technology and new availability to enhance access, I think I was surprised when we went to telehealth that some of the patients I didn't expect to be able to utilize telehealth were some of the people that had the biggest advantages of it. People who weren't able to get away from work, or were having childcare issues and couldn't get in because of childcare. People who really needed to see a counselor, a mental health counselor, and couldn't before, now could because they didn't have to go outside. They could stay at their own home and do over telehealth. So I think there's huge advantages there. At the same time, as we know that there are inequalities in our system, I think unless we are really cognizant of how those inequalities are going to affect the new technology, we're just going to duplicate and replicate inequalities going forward. And so I think we can't forget about that as we advance new technologies, to remember to always take a critical lens at who can use them and who can't. The other one, to kind of piggyback on a little bit the theme of Dr. DEGNIN there, we've seen all kinds of misinformation and a lot of mistrust in institutions, not necessarily amongst people of color, but amongst let's say some of our rural populations or some of our socially conservative populations. And I think that's, I'm curious to see where that goes going forward, and how long it takes for some of the trusted institutions to come back, and especially with misinformation and YouTube and the net and how things go there. But I think that's a theme that, while a lot of the hope that I see with people working forward, I think there are people there that are going to be left out of the conversation that at the end of the day will hurt us if we don't try to figure out how to bridge some of those gaps. And I don't know how to bridge those gaps, other than to listen and other than to try to really care about those people as best you can when we're engaged with them. So
let me piggyback a little on the telehealth thing too. I'm thinking about pathways, for example. One of the things that they're very aware of is that they can do a certain amount of telehealth, but there are cues you can't pick up over the video. For example, that a patient's decompensating. So for example, they haven't taken a shower in quite a while, but they managed to comb their hair. And so just simply having them in the room and smelling, just the smell, right? Okay, they're decompensating, there's a problem that needs to be addressed. And we just don't know how much of that's not being addressed right now, particularly in mental health. Although again, the telehealth is a huge thing to add to it. It has limitations as well.
I was just thinking too, as Dr. Royce was talking in particular, I know it sounds like we're saying we're being oxymoronic when we say that we don't necessarily trust what we're hearing when someone says it's just 7 people that got blood clots out of 7 million. But at the same time, we appreciate the fact that they seem more transparent than the previous administration. At least they paused it and told us that people got blood clots. Which at the same time is a huge risk. I mean, if it was only 7, why tell anybody about it? And so that the idea of increased transparency, things maybe slowly changing depending on leadership and that kind of thing is encouraging. But at the same time, there's still a little bit of distrust there about some of these things. And so the actual practitioner, the people within the local regional area who's having these ongoing conversations, who has established him or herself among the constituency base, it makes a big difference as to who trusts who. And people are more inclined, obviously, to take a chance if they actually trust the leader. So.
Excellent. So we are beyond 8 o'clock here, as we're about 10 after. So we'll kind of begin to wind things down. And I'd like to do so with our last question. And we have so many great questions that have come in the Q&A. So thank you to all of you who provided your questions. We've done our best to answer as many as we can, but we will not be able to get to all of them. But thank you so much for watching and participating. Several of the questions, though, do kind of hint at the idea of a new normal and what this is going to look like. Is there a new normal? Can we go back to the way things were? So many of us have had these conversations about new normals and getting back to normal, though many social scientists, physicians, advocates, researchers would suggest that that is simply not possible to go back to the norms of pre-COVID life. So what do you see, and we'll give a chance for each person to weigh in, what do you see as the most important changes or lasting effects of the pandemic, be they positive or negative, on, you know, our social worlds, our physical worlds, social justice, healthcare, death and dying, your areas of expertise? You know, what are those most important and lasting effects, given that we can't really go backwards to pre-COVID?
So I think for me, from a health disparities standpoint, one thing that I want to make sure that we don't do is quit talking about health disparities, right? I mean, the pandemic has really helped shed a light in an important way on these health disparities, but now it's time to do the work, right? So I think that that's sort of one thing. Like I don't want to see us go backwards, and not necessarily directly, you know, related to health, but I think that many of us with children have also just realized how exceptionally important our schools are, and having our kids in schools, and, you know, sort of really valuing our educators that are doing important work with our kids. So anyone that had your kids home virtual learning while you're trying to do your job and everything else, right? We know the struggles. And so, you know, I know going forward that at least in my family, we're going to do anything and everything we can to support our teachers and never take them for granted ever again.
You know, just to piggyback on what my colleague here just said, I'm not sure, and that's what's kind of scary. I was just thinking about what Dr. DEGNIN said earlier. I'm not sure, you know, whether or not people want to go back or whatever the case might be. While on one hand, we definitely believe that wealth inequality is growing, there also seems to be a change in the way people perceive wealth inequality. A case that I want to bring really home, and this is very relevant because it affects the Cedar Valley. I had an opportunity to go and hear oral arguments at the Alice Spring Court yesterday with respect to the Fair Chance Initiative, ban the box, the idea of trying to you know, take that off so that people who have criminal arrest record have a fairer chance of potentially getting a job and impressing the hiring manager, so that they can take care of self and family. Well, things didn't seem to be going as well as maybe the opposing counsel had wanted it to. And I'm paraphrasing, but when he got to the end of his oral argument, and it was clear that he was a little flustered by some of the questions that the Supreme Court justices were asking. He said, "Well, you know what? Maybe we just need to go back, perhaps, and then eliminate 216.19, which eliminates all human rights organizations across the state of Iowa." And I was thinking to myself, well, my goodness, you know, I mean, so I'm laughing because I don't know how else to deal with this insanity that I'm dealing with, right? I mean, so I guess I'm saying that just when you thought you were turning a corner, and just when you thought things could potentially get a whole lot better, because people are being more aware, they're talking about issues that they never talked about before, because now the marginalized and the disadvantaged are no longer invisible. We see them. We see them. At the same time, you've got you know, sectors of community that really want to you know, even eliminate the mechanisms that we thought helped make North America, you know, a thriving democracy, and that's scary at the same time. So I don't know what this, you know, really means for us in the next 5-10 years.
Yeah, from a medical practice standpoint, I mean, I don't think that I'll ever see pre-COVID medicine, or at least the mindset that I have has been completely formed by the COVID experience going forward. And I think there's an opportunity there to see things through a better light from the Board of Health perspective, and where I see the health department going and things. I think the health equity lens that they want to put on all of the health department's work is something that, while it was in place before the pandemic, I think that's something that the pandemic has really expressed the need for and given a platform to why we need to push this and make sure that this is at the heart of everything the health department does. And I do really, especially with the leadership that's there, really focus or feel like that's going to be a focus going forward. And I think that's something really key that we'll take away from the pandemic, and as we think about that work going forward, what that looks like. And I'm really excited for that, to continue that work with the health department.
Excellent. Dr. DEGNIN, would you like to provide us with some of your thoughts about the most important changes or lasting effects of the pandemic, be they positive, negative, just given your experience and the work that you've been doing?
Like I said, I mean, the awareness of systematic racism and income inequality has become much, much greater, but there's also that massive pushback. I'm not sure which way it goes. So I'll end with a little story. One of my kind of seminal moments of systematic racism. Driving up in Minneapolis, St. Paul of all places, I go up there to dance, ballroom dance, on University Avenue. And the week before, they had shot I can't remember if it was Minneapolis or St. Paul, had shot a young black teenager unarmed in his car. And I'm driving with a friend, and I'm dropping her off after the dance, and the police lights come on behind us, and we're right within just blocks of probably where it happened. And I look at her and I say, good thing we're old white people. And sure enough, as we pull over, their hands are on their guns. You know, I put my hands on the steering wheel and I turn the dome light because it's scary for them too. I mean, these traffic stops, particularly at night, they don't know what they're walking into. But as soon as they see we're old white people, everything relaxes, everything's fine. It's just a rental car with a light out. And but I knew that given what was going on and all the tension that was going on, and I saw the hands on their guns, they were scared. I mean, they were scared too. So, and I just hope that someday none of us have to say things like that or know things like that. So, my little brother, who is African American, he will not come to Waterloo because he's too nervous about the reputation of Waterloo. So.
Thank you for sharing your story, Dr. DEGNIN. I mean, I think you bring up some very, very important issues of dealing with or making visible the systematic and institutionalized racism that we see affecting our communities. So I do want to take a moment to again thank all of you for providing your very important perspectives on the challenges, some of the successes that our communities are seeing, the intersecting inequalities, the dual virus of COVID and racism. This is a very important conversation that by no means can be bounded by an hour and 15 minutes, but we very much appreciate what you've all brought to the table this evening and hope that this is a small conversation that will go out into our communities at UNI and in the broader Cedar Valley to encourage people to be informed, to be inquisitive, to ask questions. So thank you, Dr. KYSAR-MOON, Reverend FUNCHESS, Dr. ROISE, Dr. DEGNIN, and to all of these sponsors for this evening's diversity colloquium, as well as all of our participants who put in questions and stuck around with us to have this important conversation. So thank you all again for being here. And with that, we will end this evening's diversity colloquium. So thank you all and have a good evening.